I do want to move on to our last speaker in this session, who is Elizabeth Blaney, who is our gastroenterology representative for our Center of Excellence. She gives a fantastic talk and was one of our more popular speakers last year. And she's going to talk about management strategies for GI involvement with amyloidosis. So Dr. Blaney, take it away.
All right, well, thanks for the kind words. So we'll keep going through this pretty fast in the interest of time, but we're hoping to cover GI manifestations of amyloidosis, approach to diagnostic testing, and symptomatic therapies. And overall, keep in mind, how can gastroenterologists help in the care of these patients as an overarching theme? Well, Dr. Gilmore, led us off with this fantastic talk about, how do you come to think about amyloidosis so you don't miss the opportunity to make the diagnosis? And it is a challenge because, as he mentioned, there's often non-specific findings, overlapping presentations with more common disorders, and that does lead to the potential for diagnostic delays. And when we hear hoofbeats, we are supposed to think of horses, but sometimes we need to connect the dots and see that it's actually a zebra that we're dealing with. But in GI, we have a lot of horses. So sometimes it feels like everybody's GI tract is dysfunctional. In fact, though, about 1 in 4 adults have bowel problems chronically. And at least, or over half of patients have at least one GI complaint over the course of the past several months. This is usually benign things like heartburn, but we don't want to miss the opportunity to make these important diagnoses. We have to think about insidious processes like GI tract cancers and systemic disorders like amyloidosis. We have these, we come to rely on those red flags. Dr. Geisler mentioned that she is looking for that in neurology, and we're looking for that in GI as well. And for us, we're looking for weight loss, signs of GI bleeding or malabsorption, progressive symptoms that aren't responding to our typical treatment courses, and then new onset symptoms in patients who are kind of middle-aged or older are always suspicious. So then we look to pull together our red flags and those clues when we take our review of systems, thinking about things like the bilateral carpal tunnel that she already mentioned, and other features of neuropathy or other organ involvement. Those can help raise that bar of suspicion so you think about amyloidosis and don't miss the opportunity to make the diagnosis, hopefully early. So that way the patient can get those targeted therapies that a lot of our other speakers are going to talk about today. So how does amyloid cause GI problems? Well, it depends on where it's involving the GI tract and how that can disrupt the function that's happening at those tissue layers. So when amyloid is in the superficial layers of the bowel, then it's going to disrupt the mucosal integrity. So you can get bleeding and malabsorption, and that can lead to problems like diarrhea. When amyloid deposits in the deeper layers of the bowel, that's where the muscles and nerves are, and those can disrupt the motility of the GI tract. You can also see mass-like lesions or thickening of the bowel. And our hypothesis is that amyloid starts out depositing itself in the submucosal space where there's a lot of vessels. And across all types of amyloidosis, we see that 90 to 100% of the time, the amyloid is in that perivascular submucosal space. Then you may get stepwise worsening of disease because you get mechanical disruption of those smooth muscle layers, and you can get dropout of cells like the interstitial cells of Kajal, which are responsible for helping regulate the motility patterns of the GI tract. So when we disrupt the motility in the GI tract, that can cause either rapid or slow transit. It can cause retention of the stomach or gastroparesis. And all of that altered motility pattern is a setup for a small intestine bacterial overgrowth. So when we get that SIBO, that can cause continuous diarrhea, patterns of alternating diarrhea and constipation. It can lead to bloating symptoms, malabsorption, and weight loss. So when we think about approaching GI tract workup, it helps to try to cluster symptoms to upper or lower GI tract so you kind of know where to look for it, because we want to go after the involved, the clinically suspected involved organ. So in those patients who develop red flag presentations, endoscopy is really the best diagnostic tool because it allows us to directly visualize the GI tract, take a biopsy to look for the amyloidosis, and we can confirm that by Congo red staining, and then go on to do the subtyping that Dr. Gilmore mentioned is so critical to guide our targeted treatment approach. The endoscopy also allows us to rule out or find other pathologies. So again, I mentioned there's a lot of things that can kind of go wrong in the GI tract. We may find H. pylori gastritis, erosive esophagitis, complications of GERD, peptic ulcer disease, colon polyps, or neoplasias. So all of those other common GI problems can be coexisting in patients with amyloidosis or be other independent problems. In some cases, endoscopy can also be therapeutic. So particularly in patients who have dysphagia, this is a great diagnostic test because it may allow us to also go on to treat the patient by doing a dilation, for example. Across the types of amyloidosis, we see that AL lambda amyloidosis is the most common type for GI tract involvement. It's got a pretty high prevalence throughout the GI tract, but there is a gradient of increasing deposition going down towards the rectum. ATTR is the second most common type, and it has the highest prevalence in the colorectum. So that's important to keep in mind because that's a good place to seek it if you're looking for the diagnosis. AL kappa and AA amyloidosis have an opposite pattern of being higher represented in the stomach and duodenum, so you may want to look for that there. Of note, the colon, at least in this data set, was the most highly biopsied site, so that may be why it's well represented as a high-yield organ. The submucosa is actually needed to make that amyloid diagnosis sometimes, or it may miss up to 60% of cases. And TTR is at the highest risk of getting missed because you don't get the submucosa. The photo at the top panel shows AL amyloidosis, and there's a vert involvement here. It's tough to miss this because the tissue is clearly abnormal and eroded. There's petechial hemorrhages in the submucosa. And then on the biopsy, you would see chunky amyloid deposits that you don't even really need a Congo red stain to know what's going on here. But unfortunately, sometimes the amyloid deposits may be small, and that can be even in patients that have really severe GI tract dysfunction because of how the amyloid has impaired the neurological function of the GI tract. This, again, it can be a problem with TTR. The yield increases the more sites that are sampled. In the stomach, there's higher yield if you take 3 samples. And then there's also higher yield if you biopsy something that looks visibly abnormal, except the good news is the duodenum and rectum have the same high yield for biopsies, even if the tissue looks normal at the time of the scope. So the other thing that's important to keep in mind is the critical importance of requesting those Congo red stains, because our center has accumulated many case examples where the initial pathology read didn't pick up on the amyloidosis, and it was only discovered when we went back and requested add-on Congo red stains. And this was just a algorithm of approaching that type of workup. And now there may be other diagnostic tests that are useful here, and some of this is going to depend case by case. So patients, may require abdominal imaging, particularly if there's concerns about obstruction or pseudo-obstruction. Nutritional labs are very important in patients who are having weight loss, particularly if there's diarrhea. And I found a lot of zinc deficiency in amyloidosis patients, which isn't something that necessarily gets checked routinely. So that's important to look at. And then it also can help to do motility assessments. And there's several tests that gastroenterologists have in our toolbox that can help us evaluate patients. And it may be a point that if you're thinking about doing these, this would be a good time to loop in a gastroenterologist to kind of help with interpretation of these tests, because things like breath testing only have a 60% accuracy. So having somebody else to kind of work through these issues, particularly if you're needing to order these studies, may be useful. When we think about managing GI amyloidosis in terms of the symptoms, it helps to keep in mind that about 1 in 6 patients with amyloidosis have GI symptoms. That's not terribly different than the general population. Overall, AL patient subpopulation has more GI symptoms, and patients tend to have more GI symptoms when they're also have volume overload. Of those who've had GI symptoms and undergo biopsies, it's notable that the biopsies aren't reliably predicting what their symptoms are. So only 45% of a set of amyloid patients who underwent biopsies actually had positive biopsies, even though they were having symptoms. And it could be that these patients have involvement that the biopsies aren't capturing, or they may be fulfilling criteria for other common functional GI problems. As I mentioned, this is common in the general population. So when we look at treatment approaches, the approaches are the same. We still have the same kinds of tools in the toolbox, whether their biopsies are positive or not. And the way we approach treating patients is really abstracted from the options that we have from severe forms of functional disorders. Diabetic gastroparesis and intestinal neuropathy are probably the most analogous. Therefore, just like with these other disorders, a gastroenterologist can be about a valuable resource in helping the patients that have significant symptoms, because there isn't a one-size-fits-all approach. And this is why I love my job and the job security that goes along with it. What we want to do is try to intervene on these patients so that we not only improve quality of life, but we avoid a downward spiral of malnutrition where patients start losing weight and they become more and more depleted in terms of macronutrients and micronutrients. They become frail, and then that ultimately can lead to death. So we want to help patients early as possible in the treatment course, optimize their oral intake, utilize a dietitian, oral supplements, vitamin replacement, and in some cases, enteral nutrition support or even parenteral nutrition support in select cases. As we look to approaching nausea and vomiting, there's an overall many pathways that could be relevant. So trying to think about what may be happening in a particular patient can be useful. Often patients will have symptoms of heartburn or dyspepsia that may respond to acid suppression. Dietary management is the mainstay of a slow functioning stomach, but then we also will often add medications that are trying to help with symptoms. And in terms of Prokinetics, the only FDA approved option that we have for gastroparesis is metoclopramide, which isn't my favorite drug because of its toxicity profile, CNS toxicity, cardiac arrhythmias. So if we use that, we need to monitor them. And then there's a new agent in the last couple of years that is FDA approved for chronic idiopathic constipation. Prucalopride, though, is a 5-HT4 receptor agonist. And so that's present throughout the GI tract and promotes motility. So it's a good option to think about in patients who have a slow upper GI tract, but also have slower bowels, because it may, there's some data that it may improve stomach issues as well. When we think about symptom palliation, we try to utilize antiemetics because that is a predominant symptom for many patients. And in those who have kind of refractory symptoms, there's some data for using olanzapine in palliative care. And then we look to borrow medications from the realms of neurology and psychiatry to function as neuromodulators. And there's a little bit of sophistication here that I try to approach with each patient, looking for what pathways may be most relevant in terms of the symptoms the patient is experiencing, but also thinking about, is there a dual indication for something like depression or anxiety? Because again, the GI tract is this whole network of nerves that these distressing symptoms, of bloating, fullness, and intestine distress that we can intervene on potentially with our pharmacology. We also want to address the distressing symptoms of altered bowel patterns of diarrhea or constipation, and in particular, aim to get control of fecal incontinence because that has some of the worst impacts on quality of life of any symptom patients can experience. I included this list of a bunch of things that can cause diarrhea, just because when people ask why would I want to become a gastroenterologist, if you say you think it's interesting, they look at you as if maybe there's something wrong. But I think this summarizes the fact that this really can be interesting because there's a lot of complex factors that could be playing into what is happening in an individual patient. And in someone with amyloidosis, all the factors are potentially on the table. So there's many possible things that can be going on. So again, if somebody's not doing well, pulling in a gastroenterologist to help sort through these possibilities can be helpful. When we approach treating diarrhea, we can max out antidiarrheals, usually starting with loperamide, but then adding prescription antidiarrheals. Some patients with amyloidosis may have bile salt malabsorption as a mechanism, so bile sequestrants may be useful. I mentioned earlier that amyloidosis is a setup for SIBO, and so sometimes these patients require antibiotics to suppress that, and they may need cycles of antibiotics to keep things under control. Rifaximin is kind of a designer drug for this because it's non-absorbable, but its high cost limits the utility, particularly if the patient's going to need frequent courses. Doxycycline may be an appealing option because there's some data for this as an anti-amyloid therapy. And then in patients who have refractory diarrhea, once you've tried a lot of other things and done a nice assessment of what could be going on, there's several case reports in TTR, AL, and AA amyloidosis of using octreotide for refractory diarrhea. It may improve motility patterns, which would help suppress SIBO. And basically, it's a shutoff valve for GI tract secretion. So you're just going to decrease the fluidity of what's coming through the GI tract. But it's got high cost and side effect profile that don't make that first line. In terms of constipation, again, helpful to think about mechanistically what's going on. Fluids and fiber is mainstay for mild constipation, but in motility disorders, it doesn't work well. So then we typically add traditional laxatives. There's data that polyethylene glycol, or PEG, is more effective than lactulose, which causes a lot of bloating, because basically you're giving them lactose intolerance. Lactulose compares favorably to Senna, and recently there was a paper that compared Senna to PEG, and PEG came out a bit ahead on that. Docusate is a stool softener. It's mush without push, and there's no data that it really helps constipation. In those who don't do well with traditional laxatives, there's a lot of prescription laxative options now that are often well tolerated. Linaclotide, plecanatide, lubiprostone all work by activating secretory channels in the GI tract, which will add fluidity to the bowels and in turn stimulate more bowel movements. Prucalopride, again, is a prokinetic, so that has some appeal here of maybe being a good option. And in those on chronic opiates, opioid antagonists can be very effective. Often what we pick for this relates to cost and coverage considerations. So my concluding thoughts were that the manifestations of GI amyloidosis, again, are broad and overlap with common functional problems, but are alarm symptoms for the GI tract, and looking for those systemic clues can raise our index of suspicion to think about amyloidosis so we can make the diagnosis. We want to do endoscopic biopsies and be aware of the potential pitfalls there. Make sure we ask for stains. Symptoms don't reliably predict our biopsy findings, but that's okay because we can still help patients by treating their GI tract symptoms. And the symptom management we're pulling from the treatment of severe forms of GI functional disorders. So gastroenterologists can help in the care of these complex patients. And that's it.
That was really fantastic. Thank you, Dr. Blaney.